I was asked to discuss non-operative versus operative management of osteo, but this has largely been covered by most of the prior speakers. Good. So again, I have no conflict of interest for this. I think what you're hearing, for example, we just heard a disagreement on whether biofilms are or are not of clinical significance. As an example, I was fascinated by using quinolones because a lot of my patients have arrhythmias and good reasons why, at least as a podiatrist, you're an internist, you have a broader view. I don't jump on quinolone antibiotics. I worry about things like quinolone-associated disability syndrome and so forth. But the point is, it goes back to what this whole discussion this morning goes back to what William Osler said over 100 years ago, and that medicine is a science of uncertainty and an art of probability. And that's what it is. And there's always going to be people who second guess you. So this is the practical issue that Dr. Lavery brought up. And everyone in this room who's a podiatrist knows the reality of it. Thursday, I had a good-sized guy, diabetic, ex-Marine, nice guy, diabetic, significant neuropathy, cavus foot. He already had resection of his fourth ray, and he's got a horrible hallux limitus, just horrible. His hallux is plantar flexed, and there's no way you're going to get it up. He had an ulcer, offloaded him, it healed. As soon as we get him back walking, the ulcer's back again. Had significant vascular disease, interventional cardiology took care of that with a note, go ahead and operate on him. So he needs a Keller, in my opinion. And I talked to him and his daughter, and I said, listen, you've already lost a fourth Met. Once I do this Keller, you're going to lose weight bearing under your first Met, and the chances are excellent you're going to get a transfer ulcer. And like Dr. Lavery said, we could play with shoes, do inserts, do this, do that. But you got to remember that these people also have motor neuropathy, so their joints are unstable. You know, it's been shown that, 50% of diabetics have an intrinsic minus foot at the time they're first discovered to have diabetes. So they don't have normal stabilizing muscles in their feet and their legs, and it goes on and on and on. So as podiatrists, we look at this and we say, well, the more bone I take out, the better I'm likely going to cure the osteomyelitis, but then we all know there's going to be biomechanical consequences of what we do. And it's an inevitability. So, you know, we get these transfer ulcers, and we need to explain this to patients. And as Larry pointed out, you know, you amputate the big toe, especially in the presence of motor neuropathy. They rapidly develop digital contractures. Now what do? I mean, you could shoe them all you want. It's going to happen. So do you do tenotomies on every toe? Do you do arthroplasties on every toe? Do you just say, let's go ahead and get the TMA done now because that's where you're headed? And I think this all requires a serious discussion with the patient and their family, because we know the reality of this. You know, I don't do TALs on everybody with 4-foot lesions because some academic told me that the ulceration heals faster, because sooner or later they have to rewalk on this thing. And again, a lot of these are older people. They've got gait instability to begin with for any number of problems, sensory neuropathy, they've got motor neuropathy. Now I lengthen their Achilles tendon or do a gastroc. Now I've given them a 4-foot instability, and then I wonder why they fall. But all of us see this all the time, these one after the other, these transfer lesions. And as Dr. Lavery pointed out, this is all predictable. So you amputate the great toe, and we know there's a high risk of complications in the long term, and if anything, it's a temporizing procedure. Same thing with partial first ray resections. We could cure the osteo, or hope to cure the osteo, run them through their antibiotic regimen, but we know this patient is likely doomed to transfer ulceration and more problems. Okay, and you got to take a broader view of all of this, and this has been shown in study after study after study. But those of you in practice know this is going to happen, and you think about that because you know the fate of that patient that's going to occur in the long term. So with osteomyelitis, we face this issue of surgery versus antibiotics, and you've heard about this already. So this is an older case of mine, but I'll show you where I think in hindsight, because Albert Einstein said, the only true knowledge is experience, and you're going to learn through experience. When I work with the residents, I tell them, I wish I could teach you everything that I think I've learned, but unfortunately, you have to experience it and go through it and learn by trial and error. So I used to, go ahead and resect out the ulcer. I would almost treat this like a cancer and then resect the underlying bone. Now, in hindsight, I don't think this is adequate bone. Now, we've had discussion here about clean margin cultures, but one of the factors that's never discussed is exactly how much bone was removed. Because once I take out a metatarsal head, I've lost weight bearing of that metatarsal, right? So does it matter if I take it distally or I take it almost to the base or I take it mid-diaphysis? We've made that bone non-weight bearing. So that one of the things I tell the residents that I think I've learned is that if I'm going to resect a bone, in general, my priority is getting rid of the bone infection. My priority is not biomechanics anymore, because once I've destroyed weight bearing, I've destroyed weight bearing. And I think it's common sense that the more proximal you resect the bone, the less likely you are to get positive pathology and positive clean margins. And when I would take these bones distally, the problem is I don't think I was coming proximal enough to get a decent clean margin. So we resect these bones. You should get bone for culture, bone for pathology. Every time I go to a meeting and I ask a survey of people in practice, how many of you take clean margin cultures? Almost nobody actually does. And then sometimes we do things to try to decrease the incidence of osteomyelitis. I'm big on throwing vancomycin powder into the wound, and I'm big on using antibiotic impregnated either absorbable or beads or non-absorbable. You've seen this discussion because we even see disagreements between, say, IDSA and International Working Group Diabetic Foot, and then other recommendations on exactly how long do you give the antibiotics, but some of it depends on did you have a clean margin culture or not. So we've seen these numbers already, and they've changed over time. And then we have this issue of what if you have a positive clean margin? So, we see variations between 3 weeks and 6 weeks recommended. And then how long should you follow these patients? Now, Dr. Lavery gave a nice talk about using procalcitonins and ESRs and so forth and so on. But if I'm not mistaken, the International Working Group says follow these patients for 6 months. And that's what I talk to patients about. They have to understand the reality. So I tell them the current recommendation of the International Working Group is follow them for 6 months. So I'm going to have you back for periodic labs. I'm going to have you back for periodic x-rays and what else we need. So don't just dismiss them, as Dr. Lavery said, but you got to do something when you see them. And you want to document, do they have resection or not? So in my opinion, one of the things that's always lacking in these studies when they look at clean margins is where did you resect that bone? What is the true extent of bone resection? Now, you heard from one of the speakers, that, and this has been looked at, that if you have a positive probe the bone test and you have x-ray changes of osteo, you don't need to go any further. It's osteo. And it probably is, except for one thing. What is the extent of that osteo? If you looked at Searney-Mader classification, is this localized? Is it just an osteitis where they had an ulcer, contiguous spread to the outside of the metatarsal, for example? Is it inside the metatarsal but distally, or does it extend the entire length of the metatarsal? I don't get that information from a positive probe the bone test and an x-ray, because all of you know the x-ray changes follow the bone destruction. I thought this was an interesting paper from 2017, and what they did was they made a suggestion. They said, get the MRI, have them measure how far back the osteo goes, and then resect the bone 1 to 1.5 centimeters proximal to where you see the MRI changes. And they looked at, and they sliced the bones up that were taken out, looked at their probability, and don't forget that MRI shows osteo, but also shows inflammation. So the MRI is typically going to make the osteo look more extensive than it really is. So you would assume if you resected the bone based on the extent of inflammation plus osteo, that you probably have a better chance of getting a clean margin. And as you'd imagine, the farther back they went, the less likely you were to get a positive margin. But if you go even farther back, you're even less likely probably, and I don't know this, I'm sure, Larry would stand up and go, well, you don't have statistical data for that, and I don't blame him if he said that, but logically, I think the farther back you go, the less likely you're going to get osteo. The other problem is how do you define osteomyelitis pathologically? Because Dr. Lavery showed the data, I have the same data I was going to show you, that how reliable are clean margin cultures? Do you change your gloves? Do you irrigate the wound before you take it? Do you exchange your instruments out? I mean, all the time I'm stopping people, not because they're stupid, but because I've learned that you don't use the same pickups or the same rongeur to get a clean margin that you just use to debride out infected bone. Change your gloves, everything's got to be changed. And so these cultures are not always reliable, but even with pathology, the question is how do you define osteo? And there's still no universal agreement as to how pathologically to define osteomyelitis. I mean, you've got this concept here of 1 to 5 neutrophilic granulocytes, but inflammation's inflammation. And I mean, and you take something like a Charcot joint in osteo, I get tired of getting calls from the pathologist asking me what I think. I go, you're the pathologist. If I knew whether it was just Charcot or infection or a combination, I wouldn't have sent you the specimen. So, you tell me what you see. So realistically, these are the things you have to do to depend on these things. The other thing is looking at patients that had negative cultures. And this particular study, they did DNA sequencing and showed theoretically, no, even though the culture was negative, you do have bacteria there. You're just not picking it up. Maybe these germs are fastidious, whatever. So you can't always rely on these things. And so I always get cultures, I always get biopsy, and I come back as proximal as I can, because once I've ruined the biomechanics of that, okay. Now, also you've heard this discussion of antibiotics without surgery, and everybody's pretty much covered this topic. This was the paper that changed my mind. It was a simple study. It was 4-foot osteo toes, metatarsals, and they looked at antibiotics versus infection. So what I have to add to this conversation is this. I'm busy in practice. I try to stay academic. I work with residents. I like teaching with residents. I like to learn. And I guess I was going to say till the day I die, I'll keep trying to learn, but I don't want to keep saying that because I'm pushing this one too close. But in any event, I tell the patients this. I sit down with their family and I tell them the reality. I say, especially if it's 4-foot, I tell them, if we have the right patient, we can treat this with antibiotics. But the cure rate's going to be lower than if we resect the bone. And I tell them that, and I say, we have to make this choice together. Because here's the disadvantage of me taking the bone out. I'm going to have to follow you. Your weight's going to shift somewhere else, and something else is likely to happen in the long term. If I just use antibiotics, then here's the problem. I thought that was a cute slide that you showed regarding not knowing the difference between orals and IVs, but I'll tell you what the difference is. Studies show that on average, if you're not in a controlled study, the patients we're seeing in our office every day, the average patient only takes 62% of the antibiotic pills you prescribe. That's the average. So one of the problems is compliance. And when you go with orals, you have to have a reliable patient. It's not like they're in a university-based study and everybody's watching everything and they're doing pill counts. These are the average slugs that are coming to our office. And they barely get over half the pills you prescribe. So that's an issue that I also have to look to. And I got to look at that patient and say, are they going to take care of things? Lastly, what are we treating in podiatry? And I mentioned earlier, I think a lot of these contiguous spread osteos are Cyarnimators 2 and 3. They're either going to be infection on the outside of the bone or localized distally. So there are circumstances where we have an advantage because we can cut out the infection. If I was an orthopedic surgeon treating a vertebral osteo or something like that, I don't think he could readily just remove 2 or 3 vertebral bodies and cure it. So overall, antibiotic therapy does have decent cure rates associated with it, and it's supported by the most recent recommendations of the International Working Group on the Diabetic Foot. So you're not out of hand, but you have to have the right circumstances. You can't have necrotic dead bone, because if you have dead bone, how's the antibiotic supposed to get in there? If you have extreme degrees of vascular disease, how the antibiotic is supposed to get in there, okay? And if you have a non-compliant patient, it's going to be a problem. So, and there's times when we don't want to remove bone. For example, let's say you take out the 5th Met base. You all know what's going to happen. You've lost a peroneus brevis. That foot's going to swing into varus, and you're going to have a horrible deformity to deal with and probably something you're not going to be able to control. So you should probably obtain cultures always. I would recommend getting bone for pathology also, because if you have negative pathology, meaning no inflammation, and negative culture, your chance for cure is better. So, and you've all seen this, and again, follow them for 6 months. So again, it goes back to what William Osler said over 100 years ago, and that's medicine is a science of uncertainty and an art of probability. While I always appreciate academic debate, I have patients I got to treat, and I have patients I have to make decisions on. And it's going to be biomechanical balance of that foot and the implications of removing part of the weight-bearing surface of that foot versus preserving that, but probably having a slower recurrence rate. And lastly, I would ask you to think about resecting more bone, because in some of these studies where we look at clean margins, I question, well, how much of the bone did you resect? Did you go back far enough? And I would argue once you lose part of a metatarsal, weight bearing, you might as well take a much longer section of that, because at that point, your resection is based on not biomechanical principles. You're not, once you take out half the 5th metatarsal, preserving that proximal 50% doesn't maintain weight bearing. Your priority is that of curing the infection. So thank you.